whole purpose of today is to help you figure out what's going on with your spine, to help to empower you to do some things on your own independently, and also kind of give you the tools to help figure out what's going on with your back, things that you can do to help improve your situation, and reasons to give us a call, right? So at Orthopedic Partners, we do everything from medication to physical therapy to injections. We also do surgery for things that fail all those treatments. We do everything from spine, trauma, total joint replacement, basically anything from the top of the neck down to the tips of your toes. We like to say if one of our partners can't help you with a condition that you have, we have another partner down the hall who can. My specialty specifically is spine, so I do surgery for the spine, but I also coordinate a lot of non-operative care for people with spinal conditions, and I also take care of broken bones. So when I'm on call in the emergency department, I fix fractures, I do hip replacements for fractures, I deal with a lot of elderly trauma, but primarily the surgeries that I do, about 80% are spine related. So I'll give you kind of an overview of what I think some of the goals of spine surgery in general are. The big one is to decompress nerves. So when people have disc herniations, when you have arthritis in the spine, it causes shooting pain that goes down into the legs. Conversely, in your neck, if you have a disc herniation or arthritis that pushes on the nerves in your neck, it causes shooting pain that goes down into the arm. So one of the things that I do as a surgeon is to take the pressure off the nerves to alleviate those nerve symptoms. The other thing that we do in spine is to stabilize unstable segments. Sometimes when the joints in your spine degenerate, it causes instability. It can cause back pain. It causes people to have nerve pinching as a result of that instability as well. So stabilizing those segments with a fusion operation is sometimes helpful for those symptoms. Then the third thing that we do in spine is improve sagittal imbalance. So what happens is as we age over time, the discs degenerate, the bones squish down, we lose the support in the front of our spine, and we all start to lean forward. And that can strain a lot of the muscles in the neck and in the low back. People can't tolerate walking forward because they really have to work really hard to keep their erect posture. So what we do in the end stages when people fail physical therapy and medication and injections is that we do surgery to correct that imbalance. So this is just an outline of what we're going to go through. We're going to start at the top and work all the way down. And I'm going to show you some examples of some of the things that we deal with. This is actually a picture of me operating. So you can see I don't have the great posture that I should in this picture, right? In order to see what I'm looking at when I'm operating, I'm looking down. So I actually have occasional neck pain. It's due to the muscle imbalance that I have as a result of my job. And a lot of people have it for degenerative conditions. We typically treat this, and the thing that usually helps people is non-operative treatment with physical therapy, chiropractic care, medication. So I actually see a chiropractor for my neck. I do physical therapy exercises at home on my own. It seems to help keep my symptoms at bay. So the good news is that neck pain rarely requires surgery, neck pain in isolation. So we typically treat it with physical therapy, chiropractic care, but physical therapy focuses on strengthening. It focuses on building up the muscle strength so that the joints in the spine don't cause persistent pain. And the stronger the muscles are, the less axial neck pain most people have. These are some examples of exercises you can do on your own. So lateral stretching helps to strengthen the trapezius muscle, which is that big muscle that inserts on your neck and goes down into the top of the shoulder. A lot of times people have referred pain that goes into the top of the shoulder. Open chain exercises, so that's what's demonstrated here on the right. So moving your shoulders behind and really trying to open up your chain. So it's also a yoga pose as well. If any of you guys do yoga, that's very helpful for this. The chain basically is kind of the connection from the top of the head down into the base of the spine. So open chain exercises, kind of hyperextension exercises in the neck. It all helps to build up the muscle strength in the neck. Similarly, you can get degenerative changes in the low back as well. It causes pain in this area that sometimes goes into the upper buttock area. We do physical therapy, chiropractic manipulation has been shown to be very helpful. A lot of people ask me the differences between the two. In terms of which is better, most of the data shows that physical therapy and chiropractic care are pretty equivalent for helping with this. The difference is with therapy, there's a little bit more work that you need to do independently. So there's a home exercise program. There's a long-term goal to build up the muscle strength in the spine. With the chiropractic manipulation, there's less independent work that you need to do, but over time, as you continue to do your chiropractic treatment, it seems to help with pain in the long term. So that's why people have a long-lasting relationship with their chiropractor. If they have exacerbation of their pain, worsening back pain, most of them have an open schedule where you can typically get in the next day or the day of your symptoms. The manipulation seems to help reduce inflammation and help in the long term. Early mobilization is key, working with our pain specialists as well, which we have at our office. TENS units, ultrasound. Anybody have a TENS unit at home? Or have any ever used one of those before? So, there is some data that shows that it's pretty helpful with low back pain. It also helps with cervical pain as well. You can start out by just asking your chiropractor or your therapist about it. If it's something that's helpful for you when you're doing those sessions, it's something you can also get at home. These are some more exercises. These are very typical yoga poses. Apart from therapy and chiropractic care, yoga has been shown to be very helpful for chronic low back pain. It involves a lot of core strengthening. A lot of the physical therapy positions that we have people do are similar to yoga poses. So the more you build up your core strength, the more you kind of offset those painful discs and joints in your back, and it helps to improve your overall standing tolerance and your ability to reduce your pain with normal activities. Sacroiliac joint pain is something we're learning more and more about every single day. So for a long time, we didn't really have a good understanding of the sacroiliac joint. So that's the joint that connects the spine to the pelvis. And if more of your pain is kind of in the lower part of your back or off to the side, sometimes that can be a significant pain generator. And sometimes it's a difficult diagnosis to come to. We typically start, like I said, with therapy and chiropractic care, but we also do injections in the sacroiliac joint for both diagnostic and therapeutic purposes. So if we think it's the sacroiliac joint and you have certain provocative findings in the joint and you get some improvement with an injection, then we can kind of hone in on that diagnosis. And a lot of times when people have isolated sacroiliac joint pain, more so than pain in the lumbar region, they benefit from pelvic stabilization programs. This is a picture of a sacroiliac joint belt right here, which helps to offload some of the movement that you get through the sacroiliac joint. And then a fusion operation is sometimes a minimally invasive option that we do for people who have tried all those things and failed. We do it through an incision that's about that big. These are titanium bolts that we put across the joint to minimize any motion through the joint. And it's sometimes a nice way to take care of pain that's really isolated to that one region. We're going to kind of go into talking about nerve issues now. Nerve pinching in the neck typically causes shooting pain that goes down into the arm. Nerve pinching in the low back typically causes pain that shoots down into the legs. So we'll talk about nerve pinching that starts in the neck. So when people get nerve pinching in the neck, you typically get pain that goes down the arm. Sometimes it can actually go all the way into the fingertips. You can also get numbness or tingling in the fingertips as well. It sometimes happens without any specific injury. It's often in older people the result of degenerative changes in the neck, so disc degeneration or joint degeneration. What happens is these tiny joints in the spine that kind of stack up like shingles, when they get arthritis, just like you get arthritis in the hip or in the knee, the joints swell. Except in the spine, the spaces are very small. And when the joints in your neck swell, they can cause nerve pinching. And it actually happens in a very predictable pattern. So we've done studies to show that each nerve root kind of goes down into the arm in a very predictable way. So even before we get advanced imaging like an MRI, oftentimes we can say, oh, this seems like a C6 issue, so it's probably a C5-6 disc herniation. So a lot of people kind of follow a very predictable pattern. Treatment, and not to be redundant, but we always start with NSAIDs, physical therapy. We talked a little bit about traction before. Cervical traction has been shown to be very helpful as well. We literally need a millimeter or two of space more for that nerve root to help to alleviate some of the nerve symptoms. So if we do traction on a regular basis, oftentimes that can help to decompress the nerve root. It helps to alleviate the shooting arm pain. And the vast majority of people get better without needing to do anything beyond medication and therapy.
What do you mean by traction?
Yeah, so inline cervical traction, so literally having a therapist kind of gently pull up on the neck. There's also, you can get traction devices that actually help to distract the neck, things you can do at home, so collars that sort of gradually inflate and help to open up the space for the nerves that way. There are also over-the-door contraptions, so they give you a little chin device that you can do. Injections are also something that we do as well, and it's a little bit faint here, but this is basically what we call an interlaminar injection, so it goes in the space in between the bones here. It targets the nerves that are inflamed and helps to reduce the inflammation where the nerves are pinched with the goal to help to settle down some of that nerve pain.
I have a question. If you had those injections, not in the neck, but in the lower spine, and they didn't help,
yeah.
Is there any point in looking for a different provider?
Sometimes the nerve pinching just gets so severe that injections don't help. Sometimes there's so much inflammation that no amount of steroids can settle down the inflammation. It's like anything else, if what you're doing is not working for you and the provider's kind of running out of options for you, it's always reasonable to get a second opinion. What I really want to kind of impart upon everybody is, just because I'm a spine surgeon doesn't mean I think that everybody needs surgery. I think the vast majority of people I see benefit more from non-operative care than surgery. Surgery, in my opinion, is just for a very small set of people or subset of people who fail everything else. This is basically just kind of showing you what the MRI looks like when people have a disc herniation. So this line down here is the spinal cord coming down. This is the front of the spine. This is the back here. These bulging areas are where people had or get disc herniations. And this patient in particular had very severe shooting arm pain. So you can also see on the x-ray here, she's lost some of the space for her disc. So it's a degenerative process over time. It's sort of like if you make a really big sandwich and you squish the sandwich down, sometimes the contents splurge out to the side. That's exactly what happens with disc herniations in the neck. The discs degenerate and the bone squish down and the contents have nowhere to go and they can cause nerve pinching. So what we did for her is we took the disc material out, we put a spacer in to help to open up the space for the nerves, and then put a small plate on the front just to make sure that these spacers don't migrate at all. But that helps to take the pressure off the nerves to alleviate the arm symptoms that people have. Typically the nerve pain recovers very quickly, but it's always a last resort. What I see in my practice and what most of the data shows is that about 90% of people with this specific problem improve without needing surgery, but it's an option for people who have persistent pain. Cervical disc arthroplasty is something that we're doing now. It's new within the last 15 or 20 years. That operation that I showed you before is a fusion operation. In the neck, fusion operations don't cause a lot of loss of mobility, but per level that we fuse, people lose about 10 degrees of rotation. So it can be significant, especially if people already have pre-existing stiffness. So this is a nice way to alleviate the neurologic problem, and then to put a spacer in that allows for mobility and restores the normal anatomy in the cervical spine. So this is just an example of what it looks like intraoperatively. So it's essentially like a very small total knee replacement. So very similar components, metal on top, metal on the bottom, and then a mobile plastic segment in between that helps to restore the normal anatomy at those levels. In the cervical spine, you can either get nerve pinching that causes shooting arm pain, or in more advanced situations, you can get spinal cord pressure. So something I sometimes see in our elderly patients is that they get degenerative changes in the neck that causes spinal cord pressure, and people start to develop symptoms consistent with balance issues. So you feel unsteady on your feet. Yeah.
My problem sometimes when I walk on that I have a tension all over the floor.
Yeah.
It seems like I'm going to fall.
Yeah.
And I can't seem to balance myself.
Yeah, so I mean, that's something that could be related to your neck. So it's not infrequent that I see people who come in to see me because they think they have a low back issue, and it actually turns out that they have a neck issue. So the neck can also cause balance issues like that. It can cause problems with your hands. So if you start to lose hand dexterity, if you find that your handwriting is deteriorating, or if you have issues with fine motor tasks, so if any of you, knit or tie flies or, do something that requires a lot of hand dexterity and you find that you're not able to do that anymore, that can sometimes be related to this problem. Occasionally you can get numbness or tingling in the fingertips. And this problem can be progressive over time. So what we know about it is that people tend to get worse in what we call a stepwise fashion. So people are doing pretty well for a while, and then over the course of a couple days or a couple weeks, people find that their unsteadiness is worsening and they need to use a cane, or their hands get worse. And then they lose another step a couple years later where they go from a cane to a walker. And the way that we diagnose this is with a full neurologic exam. So I test head-to-toe reflexes, motor strength. Sometimes people have jumpy reflexes, or they have issues with balance or their gait. And if an MRI does show that there's spinal cord pressure, there are treatments that we can do to help prevent that from getting worse and help to improve that. So this is actually an example of an MRI. So this little ribbon right here is what this lady's spinal cord looks like. So she has very severe arthritis in the neck. Typically the spinal cord is nice and circular or heart-shaped. Hers is so flat that it looks like a ribbon. So she actually came to see me with a similar issue with her low back. I examined her, she had jumpy reflexes, we got an MRI of her neck, and it turned out it was her neck that was causing her issue. And this is just an example, two different examples of the way that we typically treat it. So there's both motion preserving operations that we can do, so something called a laminoplasty, where we bridge open the spine, or we do a fusion operation after we take the pressure off the nerves. And these are just pictures, illustrations that kind of show what we do in the operating room. So this is the spinal cord here. This is a burr that helps to kind of gently burr away some of the bone. And then what we do is we burr a little opening on the side, and then we just hinge it open, sort of like opening a door for the spinal cord to take some of the pressure off. And then after we open it up, we put a little plate there that helps to keep the spinal cord bridged open. And what people experience afterwards, after they recover from the surgery, is that their balance improves, their hand function improves, and it also prevents it from getting worse over time. Because if this goes untreated, what can sometimes happen is people get to the point where they're either either walker bound or wheelchair bound. And when it gets to that point, it's not usually something you recover from. So it's definitely something as providers, both primary care doctors and orthopedic doctors, that we're always looking for, because it's one of those early interventions that can really preserve your quality of life in the long term. Moving on down, so we talked about nerve pinching in the neck. We're also going to talk about nerve pinching in the low back as well. So nerve pinching in the low back, also known as sciatica symptoms. So when people get this problem, it typically is pain that starts in the low back, radiates down the back of the leg. Often it goes down past the knee or into the calf or foot, but sometimes it's primarily localized to the butt area. So nerve pain is literally a pain in the butt. It can be very debilitating. It's worse when people stand up straight. It's worse when you're sitting for a long period of time. People have difficulty driving a car. They describe it as either a burning pain or a dull, achy pain. You get numbness and tingling in the area. So this is an illustration that kind of shows what the nerves look like in the spinal cord. So it's sort of like lanes in a highway. So each nerve gets off at a very predictable level and goes down a very predictable pattern in the low back. They can get pinched in a variety of different locations. We talked a little bit about traction therapy. That's helpful for certain kinds of nerve pinching. And this is an example of an inversion table that a lot of my patients, they try out at therapy and then they figure out if it's helpful for them. If they get some temporary benefit with a therapist, sometimes they purchase an inexpensive device that they can do at home. And it helps to keep the nerve pain at bay for a long period of time. Sometimes if the nerve pain gets severe enough, it's not as helpful anymore. But for people with mild or intermittent symptoms who this is helpful for, it can be a long-term treatment for a lot of people's nerve issues. For anything that brings the knee up to the chest or crosses the leg, stretches the hamstring area, also stretches the sciatic nerve as well. Injections can be very helpful as well. So you mentioned injections. Oftentimes it's enough to settle down people's inflammation and nerve pinching. Sometimes if the nerve pinching is so severe, the pain is refractory to injections, but for the vast majority of people with sciatica symptoms, it improves with therapy, medication, and injections. So these are just some examples of some exercises. So this is a seated piriformis stretch. The piriformis muscle is a muscle in the butt area that overlies the sciatic nerve. So if you can stretch that muscle, it helps to loosen up some of the space where there's nerve tension that causes a shooting leg pain. Nerve stretching when you're seated is helpful, and you're able to get into this position. This just stretches that muscle a little bit more. It also stretches the sciatic nerve as well and can help to desensitize the nerve that's irritated. And then crossing the leg in front. So if you look, every single position involves bringing the knee up as close to the chest as you can, stretching the back of the butt area. All those maneuvers help to stretch the sciatic nerve and the piriformis muscle to help to reduce some of the nerve pain that people have. When things like medication, therapy, injections fail, we sometimes consider doing a surgery. One of the most common procedures that I do is what's called a discectomy. So most people who have nerve pain have a very small disc fragment that's pushing on the nerve. It's only a couple millimeters in length, but in the spine, that's a mile, right? So that can cause a lot of severe nerve symptoms. When people do therapy, injections, and medication have persistent pain, this is something we often consider based on what your MRI shows. I did one yesterday. Essentially what we do is we shave a little bit of the bone away. We remove this ligament that connects the two vertebral segments together. We gently move the nerve root to the side, and then we take the disc material out that's pushing on the nerve. So we preserve all the remainder of the disc material. We preserve all the joints. There's no fusion involved. It's typically an incision that's about 1 inch long, and it's usually an outpatient procedure. Again, it's a last resort, but it's something that we offer to people who fail everything else first. Claudication is a similar type of problem to the sciatica symptoms. The only difference is that it's arthritis in the spine rather than a disc herniation. So when we talk about nerve pinching, there's several different ways that people can get nerve pinching. In our older population, it's typically joint degeneration. So just like knee or hip arthritis, you get joint degeneration in the spine, the joints swell and they cause nerve pinching. Typically, these people have predominantly butt pain. So they don't get as much shooting pain that goes down past the knee. But if you stand up straight, that helps to close down the space for the nerves, and it tends to reproduce people's symptoms. So what people often say is that when they're shopping in a grocery store, that in order to get around and do all their shopping, they have to lean forward on a grocery cart, because that helps to open up the space for the nerves and helps to alleviate that pain that starts in the back that goes down into the butt area. So I always ask about positions that help people, and people will often offer this up for me without me even asking specifically about it. They'll say, look, it's gotten to the point where the only way for me to get around the grocery store is to really lean on my cart. So we call that a shopping cart sign. And similarly to all these other conditions, we start with therapy, NSAIDs, injections. Flexion-based exercise is a good option for people, so aerobic exercise in a flex position, so either a stationary bicycle or an elliptical machine. So if you've ever hopped on an elliptical machine, you know you all kind of lean forward when you do that. That helps to open up the space for the nerves. It allows you to get some aerobic exercise and to stretch the nerves and helps reduce the nerve pain without getting into positions that exacerbate the condition.
I got a question for you.
Yeah.
Now, before the one more back, you talk about spinal stenosis. Would you go over that?
Spinal stenosis is the same thing as nerve pinching, disc herniation, or joint swelling in the back. So that's kind of an umbrella term that describes all those things. When people have spinal stenosis, it's typically from joint degeneration in the low back that causes predominantly butt pain that goes down the legs.
Is there any cure for it?
Yeah, so you know, we always start with therapy and injections, but you know, when those things fail, we consider doing surgery.
Yeah, I had surgery, and it was worse after the surgery because I was having muscle spasms back there.
Yeah.
With the worst of the pain I went in for.
Yeah. Well, you have to be very specific about what we're helping. You know, when people have L1 to L5 issues, they typically get pain that goes down into the butt or down into the legs.
I get numbness in my feet. Is that from spinal stenosis?
Usually, yep. You know, I think in spine we have to be very specific about what the goals of the treatment are that we're doing, right? So a lot of times people have, you know, back issues, hip issues, they have nerve pain, you have muscle pain, right? So I think when I counsel people about what we're going to do, we have to be very specific about what the goals are, right? So I think in spine in general, we tend to do a very good job of helping with nerve pain, but back pain can be a much more difficult thing to fix entirely, right? So I often, when I counsel people with this specific problem, I tell them, you know, we've done therapy, injections, you have a problem that involves nerve pinching, I can help with the nerve issues, but you might still be left with some back pain after, and is it worth it, right? So if they tell me I can't live with this leg pain anymore, then I think it's reasonable to consider doing what we call a decompression or taking the pressure off the nerves. There's lots of other things that we can do for back pain, but it's hard to, in the spine, isolate back pain to one specific level. So you mentioned the L5-S1 level. When I look at an image like an MRI, I see degenerative changes often at the L5-S1 level, but also at multiple other levels as well. So the surgery, when you just kind of isolate to take care of the nerve issue, often helps with the nerve pain at that one level. But the surgery won't help with the global problem of the disc degeneration. Typically, strengthening helps with that, or medication helps with that, or activity modification. There's lots of other things that we can do to help improve those symptoms without surgery.
They were talking about fusing my L1 to L5. What does that mean?
I'll show you. Actually, that's the next slide. So in terms of, you know, surgical options for the low back, broadly speaking, we talk about decompression, so that's a neurologic decompression, also known as a laminectomy, where you take the pressure off the nerves with the goal to alleviate your leg symptoms. And then sometimes we have to supplement that with a fusion operation as well. And the fusion operation is dependent on a variety of factors, but typically people have instability or they're leaning forward and they need more of an alignment and a corrective procedure. We talk about doing fusion operations. And we either go through the front of the spine, we do it from the back of the spine, sometimes we do it from the side. So this is an implant where I went in through the side. This is what's called an ALIF, or an anterior lumbar fusion, where we make an incision on the belly and take the disc material out and put a spacer in as well. And this is a very traditional operation called a TLIF, where we go in through the back, we take the disc material out, we take all the pressure off the nerves, and then we stabilize the segment with rods and screws. Anytime I talk to people about their spinal condition, it's a patient-centered approach. So it depends on what your symptoms are, it depends on what your imaging looks like, and then I consider myself the waiter in this scenario. So my job is to explain the condition to you, to help you understand exactly what's going on, and then show you the menu of options and help you to pick which one works the best for you. If your symptoms are very severe and you've tried everything else, non-operative, then we sometimes talk about doing surgery if I think I can fix your pathology with a surgery. If the symptoms are more mild or intermittent, then we start talking about more non-operative treatment, medications or injections. Anytime I see a patient in the office, we're always going through every single option, and then it's your job to pick what you want to do. In terms of lumbar decompression, this is what it typically looks like. So this is looking at the spine from the back. This is after we shave away some of the bone. These are all the nerve roots coming down here. So this is an operation that we do for the arthritis in the joints in the spine when people get the pain that goes down into the butt area. This is a lady that I saw with a very bad problem at the L4-5 segment. She was having pain that went down into the butt area. We did a laminectomy as an outpatient procedure and her butt pain improved. This lady had a little bit more of an extensive problem. So she had both nerve pinching here at the L3, 4, and 4, 5 segment, but she also had a shifting in her spine. So her vertebral segments were unstable and shifting forward on top of each other. So she needed a fusion operation to stabilize those segments. The most important part of this operation is to take the pressure off the nerves, but if those joints are unstable, they will continue to tether the nerves and put pressure on them just from the act of the shifting when people move on a daily basis. So if you can correct that and lock it in place, it helps to prevent the symptoms from coming back again in the future. Now I'll kind of give you a peek behind the curtain. So you talk about the curtain in anesthesia that sort of separates everybody from the surgery. I'm going to show you some pictures and some videos intraoperatively. One of the things that's exciting in spine is the way that we're doing instrumentation now. The old school way to do it was to use our knowledge of anatomy and very reliable techniques and get x-rays at the end. We now have intraoperative CT scans, we have robotic screw navigation that really helps us to ensure that all our instrumentation is perfect and helps us to plan surgery and do things in a very predictable way. Sometimes we bring in a CT scanner that helps to get intraoperative pictures of the patient while they're anesthetized, and then the CT scan helps to navigate the screw trajectory. This is the robotic arm that comes in and helps to navigate based on that CT scan. And what we know about robotic screw technology is that helps to improve screw accuracy, it minimizes OR time, so it minimizes the amount of time that patients are under general anesthesia. There's no intraoperative radiation that we sometimes were using before in order to help for navigation of screws. So this is all based on the CT scan that people can either get before or during the surgery. This is the robotic arm that comes in. So this is the patient on their belly here. This helps to navigate the screw trajectory. So it helps to make sure that every screw is in the right spot every single time. It's what we're using at Bacchus Hospital. We use it at Lawrence Memorial. We use it at Wyndham Hospital. So it's been around for about 12 years now. It's really revolutionized spine care in general. It helps us to be very efficient. It helps us to minimize the amount of time that the surgery takes, which helps patients physiologically. So the less time they're under anesthesia, less soft tissue dissection we need to do, the faster people mobilize, and the better they do in general. So when I do deformity cases that require fusion up into the thoracic spine, this is an option for people. Not in the neck, and not when we go in through the front of the neck. There really isn't a role when we go through the front. Also, there's really not a role if we have to go in through the abdomen to get to the lumbar spine either. It's primarily for fusion in the thoracic and lumbar spine. This is an L4 to S1 fusion with robotic screw navigation, and everything went perfectly. And then I'll briefly talk a little bit about deformity operations. So we talked a little bit about sagittal imbalance. So what happens over time as we age, when the discs degenerate, we start to lean forward. One of the goals of spine surgery is to help to improve that alignment. So if you can get people back into a neutral posture and they're not leaning forward as much, they're not causing as much strain on the muscles in the back of the spine. So it helps to improve back pain when people have tried everything else. This is a typical scoliosis, so you can see looking at the patient from the front here that she has a right-sided thoracic curve here that comes into a left-sided lumbar curve. So this is what we call a double curve here. Sometimes happens in adolescence, but it can also happen as we age with normal degenerative processes in the spine. Surgery involves decompressing the nerves and then improving that alignment. So this is a lady that I saw last year who, you can see the way that she's standing. This is her trying to maintain horizontal gaze. So when she stands up straight, she leans forward so much that in order to look straight ahead at people, she has to flex her knees in order to improve her posture. So that's the only way that she was able to walk around to do normal activities of daily living. So over time, what had happened to her is that her disc degeneration progressed all the way up to the top of the thoracic spine to the point where she wasn't able to maintain that posture anymore, and she was having very debilitating pain. So what we did was we used the robot to navigate screw trajectories all the way up into the mid-thoracic spine down into the pelvis. And this is what she looked like 6 months after. So you can see she's not flexing at her knees anymore. She's able to stand up straighter. This is always a last resort, but for people who have tried everything else, it's a nice option to help get people their quality of life back. This is another lady who actually developed an infection in her spine, which is a very rare cause of spinal pain. But occasionally, if you have an illness that results in bacteria getting into the bloodstream, the bacteria circulate around, and sometimes they can seed a disc space in the spine. And if that happens, that can occasionally cause erosion of the spine, and people develop that similar deformity. So what she developed was a spinal deformity that essentially left her hunched over like this. So she was, when she was doing her normal activities around the house, folding laundry, she was essentially folding laundry on the floor because that was the only thing that was comfortable for her. So we did a similar operation where we took out some of that infection. We stabilize above and below, and this is her standing in the ICU the day after. These are much more dramatic examples that don't happen a whole lot, but for patients who have very debilitating symptoms, it's a nice option to give them their quality of life back. And that's all I have. I'm happy to take individual questions. I can also go back to any other slides.